Yeah, so I thought I would talk today, and it will be a kind of a wide-ranging lecture on palliative care for Parkinson's. I'll talk about some of the evidence that's out there. I'll talk about some lessons from my own career in getting into this, and also talk about something that I think is really important when we think about palliative care is about changing culture. In the world of cancer, where palliative care has been around and talked about more, there's a saying that if palliative care was a medication, we'd all be prescribing it. Because the evidence is pretty compelling that it improves quality of life. It may even improve survival, but it requires a different kind of mindset than prescribing a medication. And so for that reason, I think there are changes in culture and systems that we really need to provide the best care possible for our patients. As disclosures, I have been successful over the last 10 years in getting research funding for this work. If there are people in the audience who are interested in palliative care for any neurologic condition, definitely feel free to email me. I'm always happy to talk to people who want to do research in this area. Also, for young people in the crowd who see these slides, I've gotten way more things rejected than I would have slides to put on. So if you're getting your grants or papers rejected, that doesn't mean you're doing anything wrong. Just keep following your heart, and things will turn around. And if you're doing good work, it'll get recognized. As learning objectives, I think it's important that we recognize the multidimensional palliative care needs of people with Parkinson's. And I would say that this is truly relevant to any neurologic illness. In my clinical practice, I see people with ALS, I see brain cancer. We have a pediatric neuropalliative care provider in our practice. And as I'll say in a little bit, I think Parkinson's is just a good exemplary illness for how palliative care can make a difference in neurology. We'll talk about the evidence for Parkinson's disease and palliative care approaches, and then lastly, wrap up with some of the challenges, opportunities, and some guidance and advice for people who really want to make this part of their practice and really want to change the care that's provided at Duke or wherever you go next if you're in training. As I said, I think Parkinson's is a prototype for neuropalliative care. That there are motor symptoms, there's non-motor symptoms, there's dementia, it's progressive. Although we often don't say it this way, it is a terminal illness, and people with Parkinson's have a shortened lifespan and they die of complications of Parkinson's. So I think if we're able to develop models of care that are applicable to Parkinson's, that those same models with some notable variations would be applicable to brain cancer, ALS, stroke, and other neurologic conditions. And we can talk about that towards the end of the talk. So I don't know if people remember these books. I may be dating myself. I don't know if they're still popular, but I love Choose Your Own Adventure books when I was a kid. And so I thought I would use that as an analogy to get us into the mindset of thinking about palliative care. So we have the same person with Parkinson's, and we'll choose two different adventures. So this, I would say, is slightly better than usual care. So you have a 65-year-old man with right-sided rest tremor, stiffness, shuffling. He's diagnosed with Parkinson's, started on Sinemet, follow-up in 6 months. Pretty routine. About 7 years into the illness, he's now on a complex regimen of medications, taking them every 2 to 3 hours, maybe on an antidepressant. He may be on a bowel regimen for constipation. About 10 years into the illness, he's diagnosed with dementia. And just so people know, about 75% of people with Parkinson's do develop dementia over the course of their illness. 12 years into the illness, and after 2 hospitalizations and a prolonged nursing home stay, he gets a palliative care consult while he's in the hospital for a 3rd time. They do a swallow evaluation, which he fails. They want to see if it makes sense to get a feeding tube. And then he dies in the hospital on comfort care 2 days later. And I'm sure that anyone who's worked in the hospital can tell you how common a story and how common an ending this is for Parkinson's. And just to connect this with the data, over half of people with Parkinson's die in a hospital. Here's another adventure. So Mr. Jones is a musician who notes difficulties in keeping up as a drummer. He had a fall while jogging. I'm doing this purposefully, but we're recognizing him as a person. He attends a newly diagnosed group clinic with his wife shortly after his diagnosis to get oriented to this new serious illness. A lot of people feel abandoned and confused after they get their diagnosis. Because care is coordinated and systematic, pain from his neuropathy and shoulder is addressed early, and he gets supportive counseling for grief, which is distinct from depression. Has to do with loss and changes in our identity. Advanced care plans are reviewed annually, and goals of care for independence and comfort are clarified. His wife receives attention to reinforce self-care and help prevent burnout. Hospice is starting to follow his first hospitalization, and it triggers a sign for him and his family that time may be shorter than we like, and he has several friend and family reunions during the last few months of his life, and he dies at home 6 months after hospice starts. Very different adventure, very possible, one that I've seen a lot in my clinic, but is currently not the norm. And then I would just throw this out there to choose your own adventure, is that you wake up tomorrow morning with an intermittent rest tremor in your dominant hand. And I'll just kind of let that sink in for a second. And over the next few weeks and months, some increasing difficulties keeping up with the cognitive load of your work. And my first question here is this good or bad news? And I bring this up because there's a relativity bias in neurology. And a lot of times we feel that Parkinson's is good news and that there's treatments available. But I can tell you from interviews, from qualitative research, that it's very rarely received as good news by patients. And I think for any of us on this call, we would not perceive a rest tremor and cognitive impairment as good news, even though it's a treatable neurologic condition. So again, just kind of changing our mindset. And if we have this diagnosis, if we know we're waking up every day for the rest of our lives with this condition, possibly losing things that are important to us, what becomes most important to us in the care we receive and the systems that provide it? What becomes most important in our life, and how do we move forward? So I'll just kind of plant that there. But I want to put this out there that palliative care is really about person-centered care and connecting with people. And I think it helps us if we put ourselves in our patient's shoes as we start thinking about how we want to develop and change care. So what is the evidence that people with Parkinson's have palliative needs? This was a paper we did a few years ago on defining palliative care needs in Parkinson's. And as I teach my fellows and residents and trainees, is that science can have both scientific purposes and political purposes. And this study had both. On the political side, we had a control group of people with metastatic cancer. And we showed that people with Parkinson's actually across all stages had similar palliative care needs as people with metastatic cancer. And the reason for doing that was to change the mindset that people with Parkinson's actually do merit palliative care, that this is not something that we just do for people with cancer, and that if we're looking at needs, people with Parkinson's are right up there with other serious conditions. Secondly, and I think importantly in this paper, we showed that if we model quality of life, that we don't have a complete model if we leave out palliative care elements such as spiritual well-being, such as total burden of symptoms, and that if our goal as neurologists is to optimize quality of life, that we need to address palliative care issues if we want to get there. And then the last thing was that people with Parkinson's had unique needs that were different than people with cancer. And that's not surprising, but I think it highlights the fact that we can't have simply a consultative model. We can't simply refer our patients with Parkinson's to palliative care and expect that they would get all of their palliative care needs met. We really need to think about embedded, integrated, and hybrid models, because the palliative care needs of people with neurologic illness are different than people with other medical conditions. Palliative care needs begin with diagnosis, and this is part of why I put in that part C of the story, is that I think for any of us, waking up tomorrow with a rest tremor would be having a bomb dropped in our life. And this is exactly what people have described with Parkinson's. This paper is a little over 20 years old now, but I think it is still very relevant, is that if we think about palliative care needs very broadly, not just in terms of end of life, but in terms of spiritual well-being, identity, connection with family, emotional coping, that those things start at the time of diagnosis, sometimes start before diagnosis when people are confused and they're having issues and no one's listening to them. But we definitely need to think about palliative care needs right from the time of diagnosis. That doesn't mean people need a specialist palliative care clinic at the time of diagnosis, but it does mean that we need to acknowledge the emotional and spiritual and social aspects of having a serious illness. If we think about how we integrate palliative care over time, there's a few models that I don't really like, and so I developed this figure for a chapter that I wrote, that palliative care needs don't start suddenly 6 months before people die. They don't start suddenly at a particular stage, and they don't increase linearly across the course of an illness. There's going to be spikes and valleys. At the time of diagnosis is actually a spike. If people lose their ability to drive, need assistance with dressing, have intense symptoms of pain or constipation, those are all times where a palliative care approach may be important. Doesn't mean that we need a specialist palliative care consult, but we need to put on our palliative care hat and think about how can we address these other aspects of the illness journey. And we also have to include death and bereavement. And myself and others have been making real push for this, but for a long time, I think the teaching in neurology, even on the Michael J. Fox website, was that people die with Parkinson's, not of Parkinson's. Which is not true. Parkinson's is the 14th leading cause of death in this country. That statistic is rising. And I think it's a little bit disingenuous to say, well, they didn't die of Parkinson's, they died of aspiration pneumonia, which they got because of Parkinson's. But if we don't acknowledge this, then we don't help people prepare for the end of life. And what happens is that people die in a hospital. And I know most people are off screen, but if I was here in person, I'd ask you to raise your hands. Who here wants to die in a hospital? And I'm expecting not a lot of hands would be raised. And so we can prevent deaths in hospital. And myself and Janice Miyazaki, we have evidence that we've basically gone from a system where over half of people die in a hospital to less than 20%. When we apply palliative care, we do advanced care planning and do these things early. So the deaths in the hospital that are not pleasant for the patient, they're not pleasant for the family. Caregivers whose loved one die in a hospital actually have higher healthcare expenses in the following year. So it's stressful and traumatic. That's preventable, and we can prevent that through advanced care planning and by really thinking about prognosis and again, changing our mindset so that we recognize people early, that we recognize people at their first hospitalization rather than at their terminal hospitalization. Current models of care frequently miss palliative needs, and this is an example for Parkinson's, but I could pull up similar papers from ALS, from dementia, from almost any neurologic condition that issues such as depression, such as pain, fatigue, constipation, frequently fall between the cracks in our healthcare system. And in the case of Parkinson's disease, these are invisible symptoms. Patients oftentimes don't know who to bring it up with. The primary care doctors and neurologists often feel it's the other person's job to do. These are things that we don't often have on our checklist. And as a result, about 50% of the time, people have inadequate treatment responses because they were never treated in the first place. So just something as foreshadowing is that we really need to be systematic and comprehensive when we're thinking about the total symptomatic burden of a neurologic illness, not just the motor symptoms or cognitive symptoms that we typically focus on. To meet end stage well, you must start early. So this is a Calvin and Hobbes cartoon. Do you have an idea for your story yet? No, I'm waiting for inspiration. You can't just turn on creativity like a faucet. You have to be in the right mood. What mood is that? Last minute panic. And I feel like this is a good summary of our current palliative care model, is that we want to, quote, wait for the right time to have these conversations. And I think, and the data would back this up, is that when we wait for the right time, the conversations don't happen. We did a paper a few years ago where we looked at inpatient palliative care consultations for people with neurologic illness. And at the time of the consultation, 70% of the people were unable to communicate. So that's clearly too late. And a lot of those people were, I think over half were in the ICU, over half had chronic neurologic illnesses. So this wasn't just people with stroke who it would be hard to predict that they were going to have a neurologic emergency. So there's a need to be more proactive as we think about this. People living with Parkinson's and other neurologic illness, they don't need a crystal ball, they need a good roadmap. And as I've taught physicians about palliative care and prognosis, I think a lot of times when people ask us, what's the future hold, we feel that we're sustaining hope by answering by saying everybody's different. And while that's true, it's really the beginning of a conversation. It's not the end of a conversation. So saying everybody's different is not very helpful. None of us want to tell people, and we've all heard horror stories of people being told that they had 6 weeks to live or 2 months to live and they outlived it, or they died at exactly the time their doctor said they would because they lost hope. But if we can give people a roadmap, then they can help plan better for the future. So people want to know, where are they in the course of their illness? Where are they headed? What does the future look like? What should they be looking for? So what would be the signs or symptoms that would indicate that we're getting to a new stage of the illness? And I think importantly, what does the best, worst, and most likely road ahead look like? Because those are questions that really can help people plan. So what is the best case scenario? So we can plan, hope for the best, but what is the worst so that we're prepared for the worst? And without that kind of roadmap, again, people die in the hospital, they don't have family reunions, they make decisions that they might regret later. Prozac is not always the answer. So this says, could we up the dosage? I still have feelings. And one of the reasons I was drawn to palliative care is that I saw a lot of patients in my practice who were upset, who were sad, who were angry, who were worried. And I was not trained in medical school to talk to them about that. I knew how to diagnose depression and I knew how to start antidepressants. But I really didn't have a language at that time to talk about grief, which is the loss of things in your life, or anticipatory grief, or normal worries. And so I think being able to see that, being able to acknowledge that can be incredibly powerful for patients. We can still connect them with counselors. We don't have to become counselors, but just helping people to name their experience can be an important first step. And lastly, people with Parkinson's, their priorities align with the palliative care approach, and their preferences align with the palliative care approach. And this is from work I've done, there's work from others, is that when you describe the stuff of palliative care, people with Parkinson's far and away want it. They like this approach. They like one-stop shopping. They like the extra layer of support. So what is the evidence then that palliative care approaches can improve outcomes? If there are any people in the palliative care community who have joined Grand Rounds today, there is a bit of controversy right now whether advanced care planning is helpful or not in general. In neurologic illness, I think the data is fairly clear that it is helpful. This was a paper from Oregon showing that people with their state pulsed form, and I believe North Carolina also has a pulsed form, were 3 times more likely to die at home than people without. So doing advanced care planning, do it early, not waiting for the right time, can help people meet their goals for life and for end of life. Also, I would say here is that there is evidence that having advanced directive conversations does not increase anxiety and in fact decreases anxiety. And in my experience, people are relieved when we bring up these conversations, and we bring them up sensitively. The way I do it is that when I'm taking a social history, I'll ask people, do they have advanced care plans? Do they have healthcare proxy in place? Which is signaling the message that everybody should have this and this is routine, which is exactly the message that we want to signal. When we do advanced care planning, it's not a signal that I'm worried you're going to die the next day. So this is routine care. We're doing this proactively, and we're doing it because we want your voice to guide care. Interdisciplinary palliative care improved symptom control. So this was a study done about 10 years ago now by one of my mentors, Janice Miyazaki, showing that interdisciplinary clinic was able to reduce symptoms in people with advanced Parkinson's disease, and which I think was impressive, and also, as we'll show later, can improve quality of life. So even in people with advanced disease, people who their colleagues, and I can tell you from my experience, my colleagues had said there's nothing more we can do, but there was plenty to be done. It just had to do with the non-motor symptoms and other aspects of Parkinson's that we don't normally focus on. And I really want to take that out of neurologist vocabulary. There's nothing more to do. There's always things that we can do to provide care right through the end of life. Home-based palliative care can improve outcomes in advanced disease. These are a couple papers, one from Italy, one from the US. Jory Fleischer, who is at Rush, is doing amazing work. And I think we're seeing this now actually during the pandemic and with Zoom, is that there is a whole bunch of needs for patients who have a very hard time getting to clinic. And if we're able to get into their home, whether that be Zoom or whether that be with house calls, we can help them a lot, again, beyond where we typically stop seeing patients. And I would say, and this is something that we're looking at in our current research, is that when people go to centers of excellence, there seems to be a paucity of patients with stage 4 and stage 5 Parkinson's. And that's not because those patients don't exist. It's because they either can't make it to clinic or they've stopped getting benefit from clinic. And I think we can change both of those things by providing a palliative care approach. Barbara Vickery, and actually the group at UCSF is doing similar things in the world of dementia, has shown that nurse-led managers can improve care quality, including palliative care. So this is having either a case manager or a nurse involved to help integrate care, and this may be a cost-effective way to help care in certain systems. It's actually done a lot in the United Kingdom. And then lastly, my own work in outpatient care, showing that integrated and embedded outpatient palliative care can improve outcomes in people with moderate to high palliative care needs. And in the study, we started with this model, and this has been a model that I've used in almost every grant I've written, showing that patients get certain needs met by their neurologist, they get some met by their primary care doctor. There's a lot of things falling between the cracks, like non-motor symptoms. Nobody's caring for the caregiver, and it's really up to the patient and the caregiver to take care of other resources. And again, this comes from our research, is that people are more likely to do advanced directives with a lawyer than they are with their doctor. And the problem with that is that the lawyer creates a 12-page document that doesn't make medical sense. It says, do not resuscitate. It says no intubation, but okay to do CPR. It says, you can take me off a ventilator after 5 days. And they don't make a lot of medical sense. And so there's clearly room that we can do better. And we thought that one way of doing better was to have an outpatient interdisciplinary team that included a neuropalliative care physician, a nurse, a social worker, and a chaplain, all of whom had checklists to make sure that nothing fell between the cracks. And not surprisingly, we found 3 months into the study, people had improved quality of life, and that held at 6 months, which was our primary outcome. People had improved symptom control, better grief, better rates and quality of advanced care planning. Surprising to us, actually, motor symptoms were better. And when we looked at that in models, it was mediated by improved mood and improved depression rather than changes in medication. Caregivers had improved anxiety and spiritual well-being. They also had improved caregiver burden at 6 months that increased to 12 months. And in terms of qualitative results, people felt that with this team, they had an improved sense of guidance. They had a roadmap, and that difficult conversations actually led to improved engagement with life. So I think people's concerns that bringing up conversations or palliative care will make people depressed is not true, as long as it's done in a way that's compassionate and it's done in a way that's skillful. I would also say it's done in a way that's really focused clearly on supporting this person with what's most important in their life. It's not focused on trying to, quote, make somebody a DNR or to have a, comfort care goal in mind. It's really meeting people where they are to do the best that they can with the life that they have. And so the question came up after the study and even during the study of how do we bring palliative care to the people? So how do we do this outside of an ivory tower? One attempt at that was a study that we just completed. I'm working on the manuscript right now, where we looked at what were the gaps in community care. And we felt that the main gaps were that, one, neurologists were not getting trained in palliative care. And so we developed an 8-hour course, which is now freely available in palliative care for neurologists, and it goes over advanced care planning and pain and caregiver support, so that neurologists would feel more comfortable dealing with these subjects. And secondly, for people in the community, and this was when I was at the University of Colorado, so I'm sure the same thing is true in North Carolina, but that if you're a rural neurologist, or if you're outside of an academic medical center, you're not going to have a chaplain or a social worker or a pharmacist. In fact, we're finding now, even if you are in an academic medical center, you may not have good mental health counseling or social work or pharmacy. But we felt that if we provided these things via telehealth, and this was 5 years before COVID, that we might improve outcomes. And what we found was that we did improve quality of life. It was not as dramatic as the in-person clinic. And so we're actually starting a second iteration of the study where we're trying to provide more intensive support to see if we can gain the full benefits of the in-person clinic. But this is something that we really are actively working on, is saying, can we make this model of care work in a community setting? I think part of changing this is really going to be changing culture and systems. And I think this is because this is where people train, that we need to do this at academic medical centers. This was an editorial I wrote, Palliative Care and Parkinson's, Time to Move Beyond Cancer, but really trying to change the mindset of neurologists to start thinking about palliative care as part of what we need to do to serve the people that we are serving, that this is nobody else's responsibility. Not to say that we don't want to work with palliative medicine physicians, but that it's not the palliative medicine doctor's job to lead this. And so we are working, as Neha mentioned, we have a large PCORI grant working with the Parkinson's Foundation Centers of Excellence. And this grant, the idea behind it was to take our last study and see if we can implement that model of care across all 34 US Centers of Excellence, which includes Duke and Rochester, as well as several other very outstanding centers across the country. To make this project work, we needed an operational definition of palliative care, and we wanted to make something that was memorable. We wanted to make something that was measurable and something that was actionable. And I think these 5 pillars apply to any neurologic illness, but that we want to be systematic about assessing and managing non-motor symptoms, so using checklists, templates, or scales. We want to be systematic about assessing and managing spiritual and psychosocial issues such as grief, demoralization, anger, frustration. We want to be systematic about assessing and supporting care partners, recognizing that an illness like Parkinson's doesn't just affect one person. We want to do advanced care planning annually, and this is actually part of the AAN guidelines for Parkinson's, actually, and for a lot of other conditions now, that advanced care planning is part of our guidelines for high quality care, and that we want to be timely about referring to hospice or specialist palliative care when needed. And to us, those seem like doable. They seemed reasonable. They seemed like they met the mark of things that would be important and make a measurable difference in quality of life for people living with Parkinson's. Some of the core principles of the study is that we felt that all people living with Parkinson's deserve a palliative care approach. And this gets around a question, which I think is not a helpful question, is when should palliative care start, or who should get palliative care? And it's really not a matter of who and when, but how and what kind. And so at the time of diagnosis, that might be people have a group clinic. At the time of end of life, it might be hospice, but at all times, we recognize that this is an illness that affects the person beyond just medical symptoms. Some people living with Parkinson's need specialist palliative care, absolutely. And so this is not to say that all palliative care should be done by the neurologist. And so this is going to be a team-based effort, and creating bridges with palliative care is going to be an important part of that. This palliative approach, and this is the reason for the three-legged stool, has to be supported by palliative specialists, by generalists like neurologists, and by community organizations like the Parkinson's Foundation. And that came from a paper by a Parkinson's patient, Kirk Hall, which I refer to a lot, but really thinking about palliative care as a public health good, and that if we want to meet that need, we really need to have all of these legs, especially palliative care, neurology, palliative care, and community support to be very strong. I would say one thing about the study that I just published in outpatient neurology was that at the time of starting the study, before people were randomized, caregivers in Canada were doing better than caregivers in the United States. And that may not be surprising to people who understand how our healthcare systems work, but I think it speaks to the fact is that there's a need for advocacy, and there's a need for us to think about the systems that support care. And I think this has become even more marked during COVID, is that we see how our caregivers and our patients struggle to make things work in our healthcare system, which is not very supportive a lot of times to patients. We can't be proactive if we're not systematic. And this is something that I've gotten into some arguments with as I've been coaching centers of excellence. But just because you're a good doctor, just because you have good doctors at your center, just because you have a good sense of things, does not mean that you know when caregivers are burning out, does not mean that you know when somebody has depression. So we really need to use checklists and ask. And for people who don't believe me, I'd encourage you to read Atul Gawande's The Checklist Manifesto, which is his perspectives as a surgeon. I would also say, just to be honest with you, is that when we did our study, we put checklists together so that we would be standardized. And I arrogantly thought that I didn't need the checklist, but the other doctors did. And I can tell you that within hours of using the checklist, that I caught myself asking questions that I would have otherwise missed. So I've become a believer and very appreciative for checklists. And the last thing, and I think this is very important to emphasize, is that if the work that we're doing doesn't make the lives of clinicians better, it's not going to be sustainable. And we are in the midst of a neurology burnout crisis. And I think one of the reservations a lot of people had as we rolled out this project was, you're just going to add more things to do. You're going to add more things to my checklist. I'm already here until 8 p.m. And so as we were rolling out this project, we were very cognizant of how can we make the work of neurologists, A, more satisfying, but B, hopefully easier, or at least no more burdensome than it currently is. Because if we don't do that, this is going to be a very, very tough thing to sell. And as part of that, we did interviews, and we did surveys of healthcare providers. And what we found, and I think was really heartwarming to me, was that the vast majority of neurologists were excited about this project. They were excited about the opportunity to provide more comprehensive care. They were very excited about the opportunity to network with other centers to share best practices. And I think they saw opportunities here to improve their effectiveness and satisfaction. And that was part of how I got into palliative care. And I can tell you that since doing this work, I feel less helpless and I feel less hopeless when I'm seeing difficult patients. And so I think having the palliative care skill set really does help job satisfaction and helps reduce burnout. Barriers and concerns are not surprising. So people are worried about time. They're worried about workflow. Can the MAs do this? Can the medical system and medical records do this? And the availability of key services. Do we have enough mental health support? Do we have enough social work in order to make things work, which I think are very valid concerns. To see where we are right now and to kind of just have a starting point, we did a survey of over 1,200 Parkinson's patients and 600 care partners across the country. A third of these people received their care at centers of excellence. And just so people know about the magnitude of the study, in total, about 120,000 people with Parkinsonism per year get their care at centers of excellence. So this is a project that involves a huge number of people. And we asked patients and care partners questions about their experiences with palliative care. And what we found, which was not surprising to me, but I think is important and in some ways, should be shocking, is that we have a long way to go. So patients at Centers of Excellence did report higher rates of non-motor symptom management. They did better with anxiety and depression care. They were better at care partner support and quality of communication. For many of the things we asked, in fact, the majority of things we asked, there were no differences between centers and non-centers, and that include advanced care planning, spiritual care, hospice and palliative care referral. One of the questions that, at least I found a bit troubling is that there was no difference in people who felt that their doctors talked to them about what their future with Parkinson's would look like. So clearly a gap there. And for even the things that centers were doing better, they were still low. Less than 40% in most cases, less than 10% in a lot of cases. So for these things, these basic pillars and foundations for palliative care, for what I would consider to be outstanding person-centered care, we're not currently meeting the mark. And I'm not saying that we're not going to get there. And in fact, there's been huge progress made, but I think it was important that we see where we are before we did this project. The implementation had a lot of components to it. First, we wanted to select and empower a palliative care champion at every center, because if it was everybody's job, it would be nobody's job. And so we really wanted to make sure that every center had at least one person, if not multiple co-champions, to focus on moving things forward. And this is something that I'm actually doing at the University of Rochester across divisions, is that every division at the University of Rochester has a palliative care champion, because we're thinking about this as a department. That we were going to train all relevant members at the Center of Excellence in primary palliative care, so people would speaking the same language and had a basic knowledge of this. We were going to provide coaching for the palliative care champions and teams to do quality improvement projects to help move the needle, to develop working groups within the Parkinson's Foundation so that we can make this sustainable, and to develop central resources, to create palliative care resources at the Parkinson's Foundation that would be helpful, and I'll talk about a few of those. And then also to develop infrastructure. And actually, I believe this is yet to be approved, but that there will be some pilot research grants connected to palliative care that the Parkinson's Foundation will be releasing. The current status is actually, has gone beyond my expectations. And I think this has to do with the fact that this really resonates for providers. But 33 of the 34 US Centers of Excellence have begun the palliative care program voluntarily. And this is really beyond most implementation projects. Most hope to get a 20 or 25% response rate. So that's really outstanding. We've trained over 500 healthcare providers in palliative care, or at least have started that. A number of them have completed their training. We've done over 100 coaching calls. And we're already seeing that many centers have made visible progress on structure. They've added a social worker, they've developed business plans, they've changed their templates. In talking to people, they've increased hospice referrals. And listening to what centers are saying, we are developing tools to support them better. So one example of that is we are currently creating a series of videos so that neurologists can bring up advanced care planning conversations, refer them to the videos. They don't have to do that on their time, and then wrap up the paperwork at their next visit. And so we're really interested in finding shortcuts and tools and tips to make sure that we don't make the lives of neurologists more difficult in providing this care. A few of the things that we've learned in this project is that there's an art and science to program building. And this was a message that's come across in a number of different ways, but that structures that support palliative care are not always supported by institutions. And there are some institutions that are supportive of palliative care. There are also some centers and departments that have found ways to work within their institution to grow and sustain team-based care. And this is something that we talk about a lot in our coaching meetings, is who are the key stakeholders that will allow you to get social work support? Who are the key stakeholders who will allow you to get space for your clinic, who will allow you to do advanced care planning? It can include creating business plans, and we're creating an educational module right now around business plans. We just finished one I recorded with Michael Oken on philanthropy, how to work with administrators. And so a lot of this logistical stuff that we didn't go to medical school to learn about, is actually incredibly important, and I think is one of the keys to success. A second key has to do with teamwork and leadership and culture within the center. And I've seen some outstanding teams. I'm not going to name any names. There are famous neurologists involved who have tons of grants, tons of papers, and they don't know how to work together. They don't know how to work together as a team. And I would say that the centers that are the most successful are not the ones with the most famous people, but they're the ones that really are the best at teamwork. And that's both teamwork across physicians, being able to share templates, being able to share best practices, and also teamwork across disciplines. So being able to work with nurses, MAs, social workers, and others to really develop a complete package for care. And I think, again, not something that I anticipated when I started, but makes a lot of sense now in retrospect that teamwork is really critical for outstanding palliative care. Third is that it takes a village to provide person and family-centered care. And I think there's been more discussion about this, but we need to start thinking about and addressing the social determinants of health. And this takes some creativity because our financial model is very closely tied to the biomedical model, and that's very closely tied to physician billing. And there are ways to get social, emotional, and spiritual support, including with volunteers, including with creative business plans. In our module, and I'm happy to share this with others, we can show you how we got support from a social worker in a fee-for-service model. But these things are important and are going to take some creativity until, if and when, if ever, our medical system kind of catches up to the fact that the biomedical model is not a complete model, and we really need a biopsychosocial model if we're going to provide adequate care for our patients and their families. So to end with, I'll share a couple of lessons, and then we'll have 10 minutes until 9 o'clock. Hopefully for some rich discussion about these issues on how to implement palliative care. This is a paper that I wrote. It is freely available online, but if people are interested in these models for any neurologic condition, I'd encourage you to read it. It was written really very practically. There are checklists in it. We talk about how we use our whiteboard, but it really talks about how to set up and implement an outpatient neurology palliative care practice. So some of the lessons that I've learned, I would say along the way, the first lesson is that no matter what illness you're caring for, is that you need to listen to the real experts in that illness, and the real experts in that illness are the people living with that illness. For me, these are two people who had a huge impact in my life. Kirk Hall is the gentleman on the left, who's a man with Parkinson's disease. He's blogged, he's written a children's book called Grandpa's Shaky Paws. And his invitation to his support group to talk about death with dignity really marked the beginning of my journey into palliative care. And he's helped open my eyes to things that people living with Parkinson's are really concerned and worried about. And he continues to be an advisor for me. And in all of my research studies since that time, I have a patient and family advisory council, and he's been on it. On the right are two young women, two young girls, Carissa and Juju, who had juvenile onset Huntington's disease, and they also made a huge impact on my life. Carissa, who is the younger, was diagnosed at age 9. Her sister, Juju is younger, diagnosed at age 9. Carissa was diagnosed at age 11. Because of anticipation, they were having problems in school shortly after their father, who was in his 30s, was diagnosed with Huntington's. So just a real family tragedy. Juju was having horrible pain when I first saw her. We got her on opiates. I got her on hospice. She died comfortably at home. Her older sister, Carissa, who saw that, I still remember this visit. I was asking her about her sleep, and she was having insomnia. When I asked her why, she said she was afraid of dying in her sleep. And that to me was kind of the first time where I really understood why spiritual care was important in neurology. She wasn't, and I got a chaplain on our team. I got to see that just the fact that she was able to name that helped her sleep better. We were able to support her better. But I learned so much from her over the last 2 years of her life, not just about being a good physician and about what really matters for people living with serious illness. Lesson 2, and I would say kind of connected to that, is that we all have to face sickness, old age, and death. And after I got my adult job following fellowship, and I don't know if other people have been there, but I had a kind of an existential crisis where I was feeling very helpless and very hopeless, caring for people with diseases that I couldn't cure and that I knew were going to kill them, and I knew they were getting worse every day. And so I spent some time here, which is a Zendo, it's a Zen center in the mountains of Colorado. And I think our own spiritual journey, whatever that looks like, of getting in touch and being able to accept our own sickness, old age, and death is important for opening our minds and opening our hearts to caring for people facing these illnesses. And this might feel a little bit soft to some people, but I think it really is important that if we aren't willing to accept our own death, we're going to be like our medical system that feels like death is optional. And of course, death is not optional. And if we can't face it, we're not going to make the best decisions for our patients. Lesson 3 is finding your people. I'm happy to be a person for anyone on the call who wants to do this, but for me, my people were Jean, Julie, and Janice, who are, Jean is a palliative care physician. Julie was head of the Parkinson's Center at Oregon and also an advocate for palliative care. Janice has done a lot of work there. And they were very encouraging to me to follow my dreams and to create models of this kind of care. And it's a lot easier now than it was when I started. There's a lot more support. You don't have to reinvent the wheel, but it is important to find people who will listen and support you. Lesson 4, just do it. This has been my model for a while. I've asked for forgiveness, not permission. But I think for a lot of people who are thinking about palliative care, they're kind of waiting for all of the stars to align before they start their clinic. And I would say, do it. You're going to learn as you go. You're going to make mistakes. But there's never going to be a better time than right now to get things off the ground. And that's also advice for our quality improvement projects, that it's good to plan, but it's not good to procrastinate. Words matter a lot. When I started our palliative care clinic, I called it a palliative care clinic, and people were uncomfortable referring. And I spent the first 10 minutes of every patient visit explaining what palliative care was. And so I changed it to supportive and palliative care. A lot of cancer centers just call it supportive care. And there's a lot of evidence that people are 10 times more likely to go to a supportive care clinic than a palliative care clinic. It also makes it easier for your referring physicians to refer. And when we're talking to people, whether you're doing specialist palliative care or not, if you ask people if they want an extra layer of support, they'll say yes. If you ask people if they want to go to palliative care, they'll say no. So we want to think about the language that we use to make sure that people get the stuff they need, no matter what we call it. We want to focus on what matters most, and you know, we could even think back to that the choose your own adventure at the beginning of the talk today. But in my work over the last 10 years, these are the things that matter the most to patients. It's family, it's integrity and dignity, it's having a roadmap, it's having control of symptoms, having comfort and control near the end of life. And interestingly, maybe surprising to some people, is joy. I would put on that list. This is something I've written about. We actually have a paper coming out soon showing that when we ask people the most important aspects of their quality of life, and these were over 200 people with advanced Parkinson's, over half of their responses were positive. They were spending time with family, they were family outings, getting outside the house, music. So we don't want to lose sight of joy, even though people have a serious illness. And we want to create structures, and we want to make our clinic so that we focus on what matters most. Yes, it's important that we ask people with Parkinson's about their tremor, but is their tremor more important and a better use of our time than talking to them about things that they're truly worried about? We need to be systematic. This was an article that's now out, What's in the Sauce. And I think the main difference between palliative care and usual care, at least one of the main differences, is that we use checklists. And so we didn't miss depression, we didn't miss constipation. And that was actually some of our largest effect sizes. In fact, our single largest item effect size was that we did a better job of treating constipation than people in usual care. And these are people being seen at UCSF, being seen at the University of Colorado, who have access to social workers. But the thing is that it has to be systematic. It has to be proactive. It has to be comprehensive. So simply having access to these things are not enough. We really have to get people connected in a proactive fashion. 8th lesson is you can practice palliative care on your colleagues and administrators. I love this quote from Abraham Lincoln: "I don't like that man, I must get to know him better." I would say at Colorado and at Rochester, some of the keys to my success is not assuming that the quote pencil pushers and administrators only care about RVUs. A lot of people in healthcare administration have backgrounds in nursing, they have backgrounds in social work, and they get excited when they can partner with a clinician to create business plans and to create clinic structures that are meaningful. And so I can't tell you how many times administrators and business people have actually been my allies in getting these things off the ground. We want to develop services, not divisions. So this has been a lesson for me is at the Colorado when I left, and at Rochester, I don't call ourselves the neuropalliative care division. We call ourselves the neuropalliative care service. And my goal is to try to help everybody in the department get all of the things that they need. And so I don't want to be the gatekeeper for social workers. I don't want to be the gatekeeper for mental health counseling. And I also, in terms of the services versus divisions, is that when I develop a business plan, I'm asking for 1 FTE social work for the department. I'm not asking for 0.2 FTE social work for the movement disorder division. The first is hard to say no to. The latter is very easy to say no to. And then lastly, is as we talk about all this, that these models of palliative care are complementary and not competing. So whether it's specialist palliative care, primary palliative care, integrated clinics, we want to match the model with the need. So for somebody with early Parkinson's disease, it would be distressing and it would be, anxiety provoking to refer them to the palliative care center in the cancer center. To do palliative care there, it's better to have a group clinic. Similarly, for people with very end-stage Parkinson's disease, I don't think it's reasonable that every neurologist is the best person to see them or to get them into hospice or to manage complex pain. So we really want to match the model to the need, not think about palliative care as this large and ambiguous thing that any model can cover. And so just to kind of wrap up, I would say that to me, at least, I see this lecture hopefully as a starting point. And there are a lot of resources out there for people who want to take the next step and really start integrating this into their practice. And if you're moved, I would say, join the movement, the International Neuropalliative Care Society. We're having our 2nd annual meeting in November. We are interested in anybody who would like to join. We have a lot of committees. We have over 250 members at this point, and we're rapidly growing. But our core mission is to raise standards of care for all people affected by neurologic illness. And when I talk to philanthropists, I use the analogy of cancer and cancer centers. And if you go to a cancer center anywhere in the country, you have a social worker, you have a chaplain, you have a summer camp for your kids, you have this layer of support, and there's still more we could do with cancer. Look at equally awful illnesses in the world of neurology, and you don't get any of those things. And so it's really, again, changing the mindset, changing our standards, changing the way that we as a care community approach people living with neurologic illnesses. And that, to me, is really the heart of what I want to do with my life, and the heart of the community and the Neuropalliative Care Society is really trying to get things to that next step. There's more people I can thank than I can fit on a slide, but this work has definitely been the result of working with a lot of people, and I would say most importantly, actually, it's patients and families who I've been doing my best to listen to and who've been pointing me hopefully in a good direction. And so with that, I will stop, open things for questions, and definitely open to getting emails or talking to people offline who really want to take things to the next level.
Thank you so much, Dr. Kluger. Have you disappeared?
I'm hopefully still here.
Okay. I can't see you though. I don't know what happened on my screen. Anyway, Sneha, do you have a comment or question? Anyone else, just put your name in the chat or raise your hand.
Yeah, I was just going to say thank you so much for sharing all of this with us. It certainly has been a journey for us here at Duke as we think about how to implement these strategies and the 5 pillars most effectively in our clinic model. But as you say, I think the lessons here really apply across the board in any neurological condition, whether it's Parkinson's or Huntington's or dementia or stroke or ALS. I think there's a lot that all of us can take away from this in terms of how we interact with our patients and how we think about like 360 care.
I could maybe just add to that just a quick note, and then I see there's a hand up, but there are some unique nuances that, in terms of referrals I get from MS clinic. I get a lot of people with complex pain where they need an extra layer of support. ALS has a very different flavor than Parkinson's. Brain cancer has a very different flavor than Parkinson's. But I think, as you say, the core principles and the core pillars are going to be the same across all neurologic illnesses.
Nada?
Thank you so much for this talk. I worked on creating a clinic called the Thrive Clinic here at Duke, and very thankful for our department for supporting such a model. And that clinic was created based on exactly what you're mentioning, that you feel like the patients are just not getting what they need. It's focused, I'm a stroke neurologist, so it's focused on the behavioral and mental health support, as well as cognitive changes after stroke. So the non-motor symptoms, pretty much. It's created without any funding, so done in as realistic model as much as possible. And so I'm trying to, so what you described today is very helpful for me. And I think the main barrier that I have encountered now is just the availability of mental health support outside of a funded model. And I wanted to see whether you have any solutions for this in terms of when you got the funding to support this model and sustain it. How did you use the funding to overcome this barrier?
Yeah, so a few things, and I actually at Colorado we also had a palliative care clinic dedicated to stroke, which is important. And I would say part of the financial model can be that as you're providing comprehensive care, physicians can bill for their time. There's a CPT code for advanced care planning, and that's financially advantageous to use. One of the things, I don't know if people saw Kim Metter's editorial in JAMA Neurology is, and I don't know how things are at Duke, is it's not always transparent how things are billed. And that's why it's important to work with administrators. But at the University of Rochester, we worked with our business team and we looked at the billing that I would bring in and with the additional CPT code. And we came up with a plan for comprehensive care where some of the extra billing and spillover was used to cover social work time and other time. So that's part of the answer, is that you can do kind of traditional business plans if your administrators and institutions willing to work with you. Secondly, there may be other sources of counseling that you can tap into, and I'll mention a few. One is that chaplains and chaplain programs and chaplain residencies oftentimes are interested in working in the outpatient space and can be a source of free and additional counseling. Secondly, you may consider thinking about a volunteer program. And so both at Colorado and at Rochester, we set up peer navigators. And we found that some of the best and most important counseling came from other people with the lived experience. And so at Rochester right now, I think we have a cohort of about 12 care partners and patients who get paired with other people who are earlier in their illness journey and can share their lived experience. And that's been valuable. Sometimes doing group clinics can be valuable as a way of counseling. And it gets back to this idea is that not all counseling is going to be for psychiatric pathology. Some of it's going to be for normal coping. And then the last thing, which our chaplains and social workers did at both Colorado and Rochester, is putting together a list of community resources. And so it may be that not all of the counseling happens at Duke, but that the counseling will happen somewhere, and that we can get people connected to available counselors. And then there's clearly work to be done for advocacy elsewhere, but those were, maybe a few places that you could think about starting.
Great, thank you.
Thank you.
I have another question if no one else has a question.
Okay. Go ahead, Nada.
So you mentioned interdisciplinary clinic as compared to multidisciplinary clinic, and that's also what I'm calling our clinic interdisciplinary, because not every provider. So I have a neuropsychologist and speech therapist, and I used to have a psychologist as well before he moved to another institution as part of this interdisciplinary model. And we see the patients at different times, so it's not the same day. And then we have a monthly meeting to discuss the patients. So I'm just interested in the detail of the interdisciplinary model. Where you're all seeing the patients the same day, or do you have like meetings afterwards to discuss them? If you can talk about that, please.
Yeah, absolutely. Yeah, and that's gotten trickier. I would say before COVID, and when I was at Colorado, our team, which was myself, we had a nurse, we had a PA, a social worker, and a chaplain. We were in the same place. A patient was in a room. We rotated. We had a chance to interact throughout the day, and we wrapped things up at the end of the day. So we really did have interdisciplinary care, and we really did go through every single patient we saw that day. And we had a busy clinic. We would sometimes see 25 or 30 patients in a day. But at the end of the day, we would make sure that we went through them, all the right orders were in. Everybody had a chance to share their concerns. It's tricky with since COVID in that we're seeing a lot of people remotely. It's not always done on the same day. And so I think for us, doing a weekly interdisciplinary team meeting, making sure that we have a list of people with red flags who we have high concerns for, or who are starting hospice. But again, making sure that we have the mindset that we are caring for these individuals as a team, and that we're communicating frequently, whether that's in person, by email, or by Zoom, to make sure that we really have an integrated care plan as opposed to each of us doing our own thing.
Dr. Kluger,
I
I have a
think-
couple questions. The editorial you referenced, what was it about?
Let's see, there's several. You're talking about
Metter.
the palliative care and Parkinson's.
It was Dr. Metter, you said, in JAMA Neurology?
Oh, yeah. The one in JAMA Neurology, I can email it to you. It came out, I think, just last week, and it was about it's reduced clinical and education time in academic neurology. Yeah.
Got it.
Yeah.
I'll mail that around.
Yeah, that
And-
I think honestly is an important editorial, and it speaks to this, but it speaks to a lot of things in terms of how neurology changes, and academics have changed. And I don't know, if you feel the same way, but it does feel like, and I think this is actually true across society, are we really providing care and living in accordance with our values? And if not, what do we need to do to change that, and really think about, because I feel like some of the burnout crisis, which has not been talked about a lot, has to do with our systems and has to do with moral distress from us getting away from some of our core missions, which include education and teaching for those of us who got into academics.
And luckily, we have SNEA to help us sort that out. But here's the question I have. I'm a dementia doc. And what you said about patients stop showing up, or their caregivers, when they think we're not offering anything more than a pat on the back. And I agree with that completely. But my problem with palliative care is I don't know how to describe it to patients and their families. I know how to describe hospice. I say, well, they're doctors who care and have more time, which, is really not describing what they could get out of it. And they think of it, oh, I've got to make another visit to the hospital and park, and it's going to be a pain in the butt. And then the other thing is, my assumption is that you think the better model is where I am also trained, so they don't have to switch doctors, as opposed to me referring people to someone else they've never even met.
Yeah, I can speak to kind of both parts of that. As far as how to describe palliative care, what I recommend, for people, say from our memory care group, when they refer to me, I say, don't refer to palliative care. Ask them if they need an extra layer of support. Tell them that Dr. Kluger and his team are able to provide additional support for you and your family in terms of getting care at home, in terms of addressing some of the emotional needs and challenges that you're facing. Sometimes it's very specific in terms of symptoms, but I always do it in terms of what the needs are rather than in terms of the discipline. In terms of the ideal model, I honestly think that it's not going to be, I guess in an ideal world, I would say that all neurologists would have some knowledge and familiarity with primary palliative care. That doesn't mean, I think for you, and I've talked to Bruce Miller and I've talked to other people, is that some people they're excellent diagnosticians, they do good work there, and it may not even be the best use of their time to take on some of the things that happen with palliative care. And so at Rochester and at Colorado, we had options that we could have co-management, that people can shift their care where I'm their primary doctor, kind of depending on where they are in the illness. I would say for a lot of people with Alzheimer's disease, a visit with me maybe in the first few years, just to orient them, to spend more time going over the roadmap, talking about the big picture, maybe all that they need. And then they follow with you until a point in time where maybe they have their first hospital stay or things are really declining, at which point I might become their primary provider. So I don't think the ideal model is necessarily that everybody does everything. But I don't know that the ideal model has actually been figured out yet.
I do think the Zoom model could be the right one, where they don't have to make the visits, because usually by that point they're fairly debilitated.
I agree. And I would say too that, particularly for the conversations I have, the advantages of being in your own home and being comfortable far outweigh the advantages of being in person. And we have very meaningful conversations. I've talked to people through hospice, even on phone calls, and I've gotten a level of intimacy and things with them there. So I do think telehealth is awesome and very useful for palliative.
Why do you think it didn't work the first time? You had mentioned that the first program you set up for telehealth.
So that program, for that grant, I think the reason we didn't achieve the optimal outcomes, we purposefully in that grant wanted to keep the community neurologist as the center of care, because we didn't want them to perceive that we were stealing patients, and we also didn't want it to be that we became their primary source of care. And what happened in that grant, unfortunately, is that that the community neurologists were, even though they had the resources, they were often too busy to refer their patients. And so, whereas in the published study we did in JAMA Neurology, we were seeing people every 3 months. In the outpatient study, people were not getting referred every 3 months. And so I think the intensity of care and the proactiveness was just less than it was in the first study. And so we're in the current model, which is a kind of a hybrid model, we're increasing the frequency of contact points, but we're also opening things up to try to empower patients the ability to request some of these services directly, so it doesn't have to go through the neurologist as a gatekeeper. So we still want to keep their community neurologists as the center of care, but we also don't want them to be a barrier to them getting further care. And so we'll see. I would say that if you look in the primary palliative care literature, that's kind of a frontier for palliative care, but even in cancer, people really haven't figured out the best way to provide those outcomes in a community setting, even though we've been able to get very good outcomes in academic settings. So it seems like there's different models of care are clearly needed to help people. And for dementia, it's even more challenging. We actually did a small pilot grant for Alzheimer's disease. And the challenge there is that community neurologists don't see Alzheimer's patients all that often anyway. And so that one is going to have to be mediated through a primary care service. It's a totally different model. What's that?
The emphasis on us getting new patients in, not following
right.
existing.
Yeah, I mean, I think if we're thinking about this in terms of public health and what's going to be best for the majority of people with dementia, it's not going to be that behavioral neurologists are doing all the palliative care. It's going to be distributed models. It might be like the care ecosystem model that the UCSF group is doing, but clearly it's not going to be, that you or other behavioral neurologists who are running tertiary care clinics are also going to be doing all of the stuff of primary palliative care. It's clearly just not sustainable.
Thank you. Katie, you had a question?
Yeah, I knew we're over time. I just wanted to mention like one of the.
We have time. Go ahead.
Oh, okay. I'm one of the things I'm working on to this end is developing relationships with local long-term care facilities to bring sort of my educational passion and teaching the staff there, but also trying to figure out how to provide like house call type care in those environments. Because one of the challenges we have, like you mentioned, Benzi, here is like it's a rural environment essentially versus what Jory Fleischer is doing. It's in the city, and it's
right.
It's a different approach to house calls. And so I'm hoping I'm going to get back in touch with you. But trying to put the medical system in a different light for folks, and exactly like you're saying, like people in end stage disease, there's many things about that process that we don't know because they're not here.
And there is some good evidence too for nursing home consults. So that model has been explored to some degree, and the majority of people in nursing homes have dementia. So there's some work there, but still a lot of work to be done for sure.
Mm-hmm.
But what Katie says and what Duke is, at least for me, unique, is we have such a large rural population here that really is very different than other academic medical centers.
Mm-hmm.
Yeah, it's definitely one of the challenges.
Yeah. So I wish I could be in person and we'd have some time to meet and talk together, but maybe we'll set that up in the near future. But happy to make other times to talk for sure.
Yeah, thank you so much for your talk. And again, for your course, for anybody who's interested in the course, I know Sneha will agree with me. I thought it was very well put together and, just from an educational perspective, well designed. So
Katie, can you email out a link on that?
Yeah, I can send the link to folks. I have anyone can sign up, and it's like an online one. Of course, I found it very helpful, especially in how to broach the subject with patients. Without making it feel like you were taking something away, as Benzi was saying, sort of adding this extra layer of support. I love the roadmap analogy in particular.
A lot of good stuff in there.
That's great.
Thank you so much, Dr. Kluger.
Thank you so much, Sneha. Thanks for arranging. Dr. Kluger, thank you so much for your passion and expertise.
Oh, my pleasure. Yeah, thank you all for your attention. Have a good week.
Yeah, thank you. Bye-bye.